Are you about to enter the NICU for the first time? Maybe you were previously taking care of adult or older patients, maybe as a nurse in another department, or you just graduated nursing school or medical school. Well, the good thing is it's still medicine, and a lot of what you already know is very applicable. I mean, sepsis is bad, a high potassium is bad, active bleeding is bad, but there are lots of little things that are very different about the NICU. We were told all the way through our pediatric residency, children are not just small adults. And now I'll add that neonates are not just small children. Hi, I'm Dr. Tala, and I've been a neonatologist for 17 years. And today I'm going to cover 13 different things that you need to be aware of if you're moving from an adult-centric world to the NICU. 1, the size of the patient. Babies are obviously much smaller than adults. As an aside, if you haven't worked that out already, then maybe medicine is just not the right field for you. If you've previously been examining and moving 350-pound patients, then the NICU is going to be a lovely break for you. They are much easier to examine and obviously much easier to move, the little NICU babies. But also realize that in the NICU, there is a much larger variation than in the adult world. So in the NICU, one day you might be examining a 500-gram baby and then a 5-kilo baby. Very, very rarely in the adult world would you have somebody's weight 10 times another patient's weight that you're also taking care of. So with these massive variations in weights come some very important differences. 2, medications. So following on from the massive variations in weights of NICU babies, we give all medications as well as blood products as a dose dependent on the kilogram weight. So there's no like, oh, we'll give 1 unit of blood or 750 milligrams of augmentin to that patient. Everything is dependent on the baby's weight. Blood products are given at between 10 to 20 milliliters per kilogram, and all our medications are basically from a few micrograms to a few milligrams per kilo. Even our code drugs, for example, epinephrine, is given as milliliters per kilo. But this is another really key thing, and it kind of continues on from the huge variation in baby sizes. And that is the most common medical error is usually by a factor of 10. So basically a baby is getting 10 times too much medication or 10 times too little medication than what was kind of planned. And you can kind of see why that could happen. If you have a 500-gram patient and a 5-kilo patient, then it's easy for both of those doses to kind of appear appropriate in your mind. It also really doesn't help in the NICU that a lot of our medications are often like in the 10 times kind of table. So for example, Lasix is given at about 1 milligram per kilogram. Morphine is given at about 0.1 milligram per kilogram. Fentanyl is given at about 1 microgram per kilogram. Caffeine and diaryl are given at about 10 milligrams per kilogram. So you can see how easy it is to kind of mess up the factor of 10 or even the units in that situation. So when you're in the NICU, you have to be extra careful checking your medications with the weight of the baby. The good thing is that we don't use that many medications in the NICU compared to the rest of the medical world, so you will get to know all the medicines really, really well. 3, thermoregulation. This also continues on from the babies being on the smaller side. And let me just say from now, we are absolutely obsessed with thermoregulation and making sure that the babies are always at the correct temperature. And the reason for that is that we know that hypothermia in premature babies, or really all babies, and hypothermia is defined as a temperature of less than 36.5 degrees Celsius. We know that hypothermia increases mortality and morbidities in babies, especially in little premature babies coming out of the delivery room. So we are pretty obsessed with keeping babies at the right temperature. The problem is that all babies have a higher surface area to volume ratio. They also, especially preemie babies, have thinner skin and a lot less fat on their bodies. So it's very easy for babies to get very cold very quickly. In the unit, we constantly have to monitor babies to make sure that we're giving them adequate heat to make sure they don't become hypothermic. Normally, by the time the babies are about 1,800 grams or 4 pounds, their skin is thick enough, they're big enough, they've got enough fat on them to be able to keep themselves warm without any external heat helping them. And obviously, that's a requirement before a baby goes home, which is why we rarely send babies home when they're born at less than 1,800 grams. We filmed a video on thermoregulation a couple of years ago, so if you want more details, go watch that. But in a nutshell, there's 4 main ways that we need to reduce heat loss in a baby. Evaporation, dry the baby so you don't lose heat that way. Convection, where the heat kind of just blows away. So we do that by creating a nest around the baby, keeping up the walls of the isolette, having a crib with good walls on the side. Conduction, where heat is lost directly from something the baby is touching. And the way that we do that is we make sure that the baby is always near heated blankets or a heated hat. Anything that the baby is touching needs to be warm. And then the 4th method a baby can lose heat is by radiating heat to the environment. And the way that we reduce that is by actually providing heat to the baby. We increase the temperature of the room, and we also have radiant warmers. So 4 main ways that a baby can lose heat, and we try to attack all of those individually. 4, nutrition and growth. Look, I know that nutrition is considered very important in all aspects of medicine, but in the NICU, you can multiply that by about 1,000. The first thing that you should realize is that the period of a human's life that has the most growth is basically the 2nd and the 3rd trimester. So there is a lot of growing to be done for those babies. In the NICU, not only are we trying to make sure that a patient gets the protein and the essential amino acids and the vitamin C or whatever they need to heal and to maintain their basal metabolic rate, but in the NICU, we are also trying to make sure that these babies grow well. And we don't just care about good growth so we can make cute little chubby babies. If babies have good growth, and good growth basically means that their weight, their head circumference, and their length are following curves similar to how they would be growing in utero. If babies do have good growth, then we know that they have better developmental outcomes. So good growth is so important. Ideally, what we're trying to do is make sure that the baby is getting all the nutrients that it would be getting if it was still in utero, but we're also trying to do that as much as possible with a basis of mother's breast milk. For premature infants, mother's breast milk is probably one of the best medications that we can actually give the baby. Not so much or just because of the nutritional aspect, the macro and the micronutrients. We can kind of figure that out and get those to the baby. Really, it's all the other stuff in the mother's breast milk. So the probiotics, all the good bacteria, the growth factors, the immune factors, all the oligosaccharides and all the other stuff that's in breast milk that has not been replicated into formulas. So a really, really big part of what we do in the NICU every single day is making sure that babies get the nutrition they need. So we count every single ml they get, every calorie they get. We count every single vitamin and mineral and macronutrient that a baby is going to get. Often we weigh babies every day and we check their head circumference and their length about once a week to make sure that they're following those curves. So we're pretty obsessed about nutrition. 5, feedings. So continuing on from the nutritional aspect, a large part of taking care of babies in the NICU is literally feeding them. Babies can't eat by mouth or orally until they're between 33 and 34 weeks. Developmentally, they just don't have the coordination. They also have to be off significant positive pressure. In our unit, we want babies on 2 liters of high flow nasal cannula or less to actually start oral feeds. So a lot of the times in the NICU, babies are being gavage fed. So down a feeding tube from their nose or mouth into their stomach. And those gavage feeds may be just by gravity or they may be put on a pump. Depending on the unit, babies will feed every 2 to 4 hours. In just about every unit I've worked in, it's every 3 hours in the US. So a very big part of the nurse's role is every 3 hours is to prepare the breast milk and the fortifier or whatever is being added to the breast milk and to actually feed the baby. A lot of the times when they're little, this is gavage. As they're getting older, obviously it's literally to feed the baby with a bottle. Obviously, as the babies are getting older, we hope that the families get more involved with actually doing the feeds, whether the mothers are breastfeeding or bottle feeding, because obviously they're going to be the ones feeding the babies at home. 6, the immaturity of every single organ. As you all know, all organ formation is done in the first trimester. And after that, it's really just growth and development. So even though all the organs are completely formed, there's still a lot of developing to be done. So the kidneys, the liver, the heart, the lungs, the skin, even though they are formed, they're all immature and they don't all function the same way that it would in a term baby, let alone in an older child or an adult. So in the NICU, we're in this weird world where we have to support the baby and make sure we can keep the baby as alive, but we also want to do it in a way that is as least injurious as possible to all the developing organs and systems. For example, if a baby is born at less than 30 weeks, we know they're probably going to need some respiratory support just to make sure that they can oxygenate and ventilate adequately, whether it's high flow or CPAP, or whether it's positive pressure ventilation. However, we also know that just by putting babies on extra support, we know that that can be very damaging to their lungs, especially as they're developing. So what we're trying to do is make sure that they get the lowest possible support that they need to still be able to oxygenate and ventilate properly. So we are very aggressive with weaning where we can. Same thing with the kidneys. They are formed, but they've still got a lot of developing to do. They're not very good at keeping the status quo in blood, of balancing out all the electrolytes. They're not very good at concentrating urine either. So we literally have to measure every single ml that we're giving and constantly check what's going on in the blood, because we can't just trust the kidneys to do it blindly. And we're also doing whatever we can to protect the kidneys. So we don't want to give loads of nephrotoxic drugs like Vanc and Gent and Lasix, which we know are actually damaging to the kidneys. So it's a very fine balance with supporting the baby, but also allowing these organs to develop as the baby gets older. 7, oxygen is bad. Okay, this is where the NICU gets a little bit tricky. We don't like a baby to have oxygen saturations of 99 or 100%. Hyperoxia is bad for a baby, especially because we don't know if the PaO2 is like 400 at that point. Hyperoxia is bad for a baby. It increases the risk of BPD or bronchopulmonary dysplasia, which is like the chronic lung disease of preemie babies. It also increases the risk of ROP, retinopathy of prematurity. So hyperoxia is something that we really want to avoid. We also don't want the oxygen to be really low, like in the mid to low 80s, because we know that a low oxygen saturation increases the risk of mortality as well as necrotizing enterocolitis. So basically, all our babies in the NICU have alarms if the oxygen gets too high or too low. And you can imagine with the ups and downs of babies, there is a lot of dinging going on in the unit and a lot of alarm fatigue. But be ready for it and start training your mind to be just as worried about a high saturation as a border low oxygen saturation. 8, codes are nearly always respiratory in origin. In adults, most of the time when somebody is coding, it's because their heart has failed, whether they've had a heart attack or a bad arrhythmia. And when you code an adult, when you give CPR to an adult, the emphasis is on bringing their heart back. So the ratio of the chest compressions to the breaths you give is like 30 chest compressions and then 2 breaths. In neonates, the heart rate only gets really low or stops most of the time because of respiratory issues. So nearly all the emphasis on coding a baby is on making sure that we're adequately supporting their ventilation and their oxygenation. And we don't even start giving chest compressions until we're very certain that we've got effective ventilation. When we do start chest compressions, if the baby's heart rate hasn't come back after the effective ventilation, then the ratio is 3 chest compressions to 1 positive pressure breath. So very different from adults. As part of your NICU training, I would highly recommend that you become acquainted with the NRP, or the Neonatal Resuscitation Program, which basically has algorithms of what needs to be done in the delivery room depending on how the baby comes out, without a heart rate, with a good heart rate, breathing hard, needing oxygen or whatever. We actually extrapolate a lot of those algorithms and actually use them in the NICU as well when a baby is coding. So get to know the NRP really well. We also filmed a couple of videos on NRP as well. So if you want, you could go watch those as well. 9, babies feel pain. You know, a lot of people have told me that being a neonatologist is like being a vet, in that your patients can't actually tell you what's wrong. And unfortunately, for many years, people assumed that preemie babies especially, but even term babies, could not feel pain because their pain receptors were immature. In fact, as late as 1987, the AAP, the American Academy of Pediatrics, published a policy statement saying that babies can indeed feel pain. 1987, the year that Whitney Houston's I Want to Dance with Somebody came out, like way too recent. So it's a really important part of taking care of babies to be able to recognize when they're in pain. A lot of that is just knowing what their baseline activity is like, their heart rate, their vital signs, their overall activity levels, whether they're grimacing or moving around. But on top of that, we also do have objective pain scales that we use in the NICU. As well as recognizing when a baby is in pain, a big part of taking care of babies in the NICU is making sure that we don't inflict any more pain on the babies, whether that's by being way too loud, banging on the incubator, or whether it's by physically hurting them. So really, it's extremely important that we're very, very gentle with babies and very soothing. Babies don't like being moved a lot. Remember, premature babies are still supposed to be in this lovely swimming pool floating around and not being touched by anything uncomfortable. So this is a very big difference for them. We know that babies feeling less pain and growing up with more soothing touch can really help them developmentally. 10, infection control. We are terrified about sepsis in the NICU. Babies have a weaker immune system in every possible way. Their barriers to the outside world, so their skin, their gut, and their lungs, are much weaker than in an older patient, so much more likely to let bacteria and other bugs in. Also, their innate and their adaptive immunity is also a lot weaker. So it is much easier for a baby to actually get an infection. And when that baby gets an infection, it's much more likely to travel around the body. So for example, if you have a cellulitis or a skin infection or an umbilical infection, it's much more likely to go into the blood, cause a bacteremia, and even cause a meningitis. So 2 important things here. The first one is we have to be extra careful that we are not giving the babies an infection. And the most important thing that you could do is make sure that your hands stay very clean. So we're always scrubbing our hands at the beginning of a shift, cleaning them before we touch the babies. Often we'll use gloves. We shouldn't have any jewelry or rings or watches or anything below the elbow. No fake nails or anything that can be a nidus of infection. We are very, very careful about this in the NICU. But also, just as importantly, we want to recognize if a baby has an infection very early on. So if a baby's acting sleepier or more lethargic or just isn't moving as much, or if there are like physical signs, you see redness around the umbilicus or there's green phlegm coming out of the trachea, then all of those things should alert us to think, okay, we probably need to start antibiotics before this gets a lot worse. 11, caffeine is great. Look, I had to put this in, not just because I love coffee, but honestly because caffeine is probably the best studied drug in the NICU. Caffeine has been shown very objectively in large studies to decrease the incidence of apnea prematurity, as well as to decrease the risk of a baby developing BPD or bronchopulmonary dysplasia. Not only that, but longer term follow-up of babies that had been on caffeine when they were in the NICU showed that, if anything, caffeine improves the developmental outcomes of infants. In fact, the most recent studies on the caffeine trials were done when those kids were like 15 years old. And even at 15 years old, the kids that had received caffeine were doing developmentally better in some areas than kids that hadn't received caffeine. So caffeine is fantastic. Caffeine for everyone. I mean, with limits. 12, vital signs. This is another really obvious one. Babies are going to have different vital signs from adults. The only exception to this is the temperature. We expect babies to have the same body temperature as an adult. except for in a baby, as we also already talked about with hypothermia, we care a lot more in a baby when it goes out of those parameters. If a baby has a fever, like a temperature of above 100, or a baby has a temperature of like less than 97, then that is enough to start a workup on the baby. We do not allow temperature extremes at all. Generally, the younger the baby, the higher the heart rate, the higher the respiratory rate, and the lower the blood pressure. In a term baby, a heart rate is normal if it's anywhere between about 100 to 160. A respiratory rate between 40 to 60 is normal in a term baby. So obviously in a 24-weeker, we can expect all those numbers to go up a little bit. Blood pressure is really dependent on the gestational age as well as the weight and the age of the baby. Generally, the younger the baby, the lower the blood pressure. A good rule of thumb is to think that the mean blood pressure should be at the gestational age of the baby. So for example, if you have a 30-week baby, and that could be the post-menstrual age, or it could be that the baby was just born at 30 weeks. So a 30-week baby, you want the mean blood pressure, or the weighted average blood pressure, to be 30. So just think about it like that. And 13, family care. This honestly might be the biggest difference between the adult world and the NICU. And that is that the family is an integral part of neonatal care. We love it when families are present on rounds, when they're sharing in the decision making, when they're involved with the cares, when they're just trying to learn everything about the NICU and their baby as possible. Obviously, it's the parents that are going to take the babies home. So the better equipped they are and the more comfortable they feel, the better the outcomes for the baby. It's also an unbelievably stressful time for the parents. So just being more involved and feeling like they have more control over the situation really helps all the horrible emotions that the families go through. So you'll be working very, very closely with families, often updating them several times a day and helping them with cares, teaching them, moving their babies and putting them so that they can do skin to skin or kangaroo care. Honestly, some of your best relationships are going to be with some of the parents of the babies in the NICU. And really, it is a beautiful, beautiful thing. Okay, I hope that that was really helpful to you all. I'm very excited for you that you're going to the NICU. It is the best place in medicine with the best people. I think I'm a little biased. If you are interested in more neonatal education, then please subscribe to this channel. Otherwise, good luck, and we hope you love it. Thanks.